Good night, everybody. My name is Ariana Jagannath, and I am a house officer in the neurosurgery department at Port General Hospital. Tonight, I will be discussing electrolyte abnormalities. Okay, so with respect to electrolyte abnormalities, that covers a very wide scope. So I will be mainly focusing on sodium and water. Um, so sodium can be normal, it can be low, and it can be elevated. So tonight I'll be discussing both hyponatremia and hypernatremia. So hyponatremia is one of the most frequent electrolyte abnormalities seen in hospitalized patients. Normal serum sodium is defined between 135 to 145 milliequivalents per liter, with hyponatremia being defined as a serum sodium less than 135 milliequivalents per liter. The severity of hyponatremia can be subclassified based on the levels. So it can be subclassified to mild, moderate, and severe hyponatremia, with mild hyponatremia being defined as less than 135, moderate being defined as less than 130, and severe being defined as less than 125. Acute hyponatremia is defined as hyponatremia present for less than 48 hours. It's important to note that this is more clinically dangerous than chronic hyponatremia, which is hyponatremia present for more than 48 hours or for an unknown duration of time. And this is because it creates an osmotic gradient between the brain and plasma, which encourages the movement of water from plasma into brain cells, thereby resulting in cerebral edema as well as neurological compromise. So, what are the signs and symptoms of hyponatremia? It's important to note that it depends on the degree and severity of hyponatremia. So, in mild cases of hyponatremia, patients can present with things like anorexia, headaches, difficulty concentrating, irritability, and even sometimes muscle weakness. In cases of severe hyponatremia or in patients who experience a rapid drop in their sodium levels, with levels with a drop greater than zero point 0.5 milliequivalents per hour, they may experience neuromuscular excitability, cerebral edema, muscle twitching and cramps, even nausea and vomiting, confusion, seizures, as well as there's the possibility of permanent neurological injury, coma, and even death in some cases. So, just discussing a little bit more about hyponatremia in the neurosurgical patient, there are three main topics of discussion, two of which I'll be focusing on today. So the first one is syndrome of inappropriate antidiuretic hormone secretion, SIADH, which is a dilutional hyponatremia with euvolemia or even a mild hypervolemia. Then there's cerebral salt wasting, which is hypovolemia, hyponatremia due to excessive renal sodium losses. And thirdly, there's neurotrauma with other comorbidities present, such as pseudohyponatremia, volume overload, congestive cardiac failure, and renal failure, amongst some. So, how do we assess these patients with hyponatremia? So, first of all, they must be hyponatremic. Secondly, we look at the effective serum osmolality, which depends on the blood urine nitrogen levels. So in cases where the patient has an elevated BUN, effective serum osmolality is calculated by the measured osmolality minus the BUN in milligrams per deciliter divided by 2.8. In cases where the patient has a normal blood urine nitrogen, it's calculated by measured osmolality minus 5. If the effective serum osmolality is less than 275 milliosmoles per kilogram, that is considered to be hypotonic hyponatremia. We also assess the urine osmolality. So in cases where the values are greater than 100 milliosmoles per kilogram, this is inappropriately high if the serum tonicity is less than 275 milliosmoles per kilogram. We also have to assess the volume status of our patients. So, is this SIADH versus cerebral salt wasting? So, with respect to clinical assessment, we look whether the patient is volume depleted. So, on clinical assessment, does the patient have dry mucous membranes? Is there loss of skin turgor? Or are they hypervolemic? So, are there edematous? Is there an uptrend in the patient's weight? We also do a normal saline infusion test in the event of uncertain cases. So if the baseline urine osmolality is less than 500 milliosmoles per kilogram, that is considered to be safe to infuse 2 liters of 0.9% sodium chloride over the next 24 to 48 hours. Any correction in hyponatremia suggests extracellular fluid volume depletion. We can also assess volume status via the central venous pressure. So a CVP of less than 5 to 6 centimeters of water suggests hypovolemia in patients with otherwise normal cardiac function. We also assess urinary sodium concentrations if volume status is high or low. And it's also important to determine the duration of hyponatremia. So is this patient presenting with acute or are they presenting with chronic hyponatremia? So this here is just a flowchart, basically discussing what I just outlined. So firstly, identify that the patient is hyponatremic, and then determine what is the effective serum osmolality. If it is that the serum osmolality is less than 275, then we know that the patient is hypotonic and hyponatremic. Then we go on to assess the urine osmolality. Is it greater than 100? Then we know that the patient has inappropriately concentrated urine. So then assessing the volume status. Are they hypovolemic or hypervolemic, or are they even euvolemic? So if they are euvolemic, then that suggests SIADH, potentially potassium losses, or even secondary causes. So getting into continuing into SIADH, so this is the release of antidiuretic hormone in the absence of physiologic stimulus that results in hyponatremia with hypervolemia, sometimes euvolemia, with inappropriately high urine osmolality, usually greater than 100 milliosmoles per kilogram, and is usually associated with malignancies such as small cell lung carcinoma and a variety of intracranial pathologies. So how do we diagnose it? So there are three hallmark features that outline the diagnosis of SIADH, namely hyponatremia, inappropriately concentrated urine, and the absence of both renal or adrenal dysfunction. So just further dividing that into a little bit more detail, the patient needs to be hyponatremic, usually a sodium less than 134, because we know that normal is between 135 and 145. A low effective serum osmolality, less than 275 milliosmoles per kilogram. Urine-specific gravity that is concentrated, so typically greater than 1.020. High urinary sodium, at least greater than 18 milliequivalents per liter. A high ratio of urine to serum osmolality, often 1.5 to 2.5 to 1 ratio, but it can sometimes be a 1-to-1 ratio as well. Normal renal and adrenal function, as well as the absence of any signs of dehydration or overhydration. If further testing is required, so we're unable to diagnose it based on all of those features that I previously mentioned, we can do the following two investigations. However, they are rarely recommended. One can measure serum or urinary levels of antidiuretic hormone. However, this is rarely indicated since urine osmolality greater than 100 milliosmoles per kilogram is usually sufficient to indicate the presence of excessive antidiuretic hormone. We can also conduct the water load test, and this can be considered to be the definitive test. So the patient is asked to consume a water load of 20 mils per kilogram up to a total of 1,500 milliliters of water. So in the absence of any adrenal or renal insufficiency, the failure to excrete 65% of the water load in 4 hours or 80% of the water load in 5 hours usually indicates SIADH. It's important to know that this is contraindicated if the patient's starting serum sodium is less than 124 milliequivalents per liter, or if the patient has signs and symptoms of hyponatremia. So how do we manage these patients? So management of SIADH is based on the severity of hyponatremia as well as the duration of symptoms and the presence and severity of symptoms. So just going through the algorithm on the right-hand side of the screen a little bit. So again, you have a patient in hyponatremia. You need to assess the degree of hyponatremia. Is it mild to moderate or is it severe? In cases where there is mild to moderate hyponatremia, you assess the patient's symptoms. Are they asymptomatic or are they symptomatic? So in asymptomatic cases, we can proceed to the routine treatment protocol, which I will discuss shortly. And in the event of the presence of symptoms, we can proceed to managing via the intermediate treatment protocol. In cases where a patient has severe hyponatremia, so sodium is less than 125 and they exhibit severe symptoms, if they have acute hyponatremia, we can proceed to aggressive treatment protocol, which usually requires ICU admission. If it is that they have chronic hyponatremia, then we assess the symptoms. If they are asymptomatic and relatively well, we can replace via the routine treatment protocol. However, if they do exhibit severe symptoms, again, proceed to aggressive treatment protocol. So when managing patients with hyponatremia due to SIADH, it's important to ensure that hyponatremia is not due to cerebral salt wasting prior to restriction of fluids. And it's also important to ensure that we avoid rapid correction or even overcorrection of sodium due to the risk of osmotic demyelination syndrome. Definitive treatment also involves treating the underlying cause. So, in the event that the patient is anemic, we can transfuse blood products. In the event that hyponatremia is secondary to malignancy, patient can be referred for anti-neoplastic therapy. And if it is due to the use of medication, we discontinue the offending agents. So the routine treatment protocol, as I mentioned before, is usually indicated for cases of mild hyponatremia, whereby patients are asymptomatic and have non-severe hyponatremia, or they may have severe and chronic hyponatremia, however, they are asymptomatic. So this usually involves fluid restriction while encouraging the use of dietary salts and proteins. In the event that the patients may have refractory hyponatremia secondary to SIADH, one can consider demeclocycline, which is a tetracycline antibiotic that partially antagonizes the effects of ADH on the renal tubules. However, it can have variable effects, and there is the possibility of nephrotoxicity in these patients. We can also consider conivaptan, which is a non-peptide antagonist of V1A and V2 vasopressin receptors for euvolemic and hypervolemic moderate to severe hyponatremia in hospitalized patients. So getting into the intermediate treatment protocol as well as the aggressive treatment protocol. So like I was mentioning before, the intermediate treatment protocol is indicated for symptomatic non-severe hyponatremia or patients with severe hyponatremia and chronic or moderate or non-specific symptoms. So this usually involves 0.9% sodium chloride infusion with the use of furosemide 20 milligrams IV OD Q4 hourly sodium monitoring, and the overall goal is to increase sodium levels at a rate of zero point 0.5 to 2 milliequivalents per liter per hour, not exceeding 8 to 10 milliequivalents per liter in 24 hours, and not exceeding 18 to 25 milliequivalents of sodium per liter in 48 hours. And this is because of the risk of osmotic demyelination syndrome, which I will discuss in a little bit as well. The aggressive treatment protocol, like I said before, it requires ICU admission. This is indicated in cases of severe hyponatremia and acute or severe symptoms. So if patients are comatose or even if they have seizures secondary to hyponatremia. So in these cases, hypertonic saline, so 3% sodium chloride is used at a rate of 1 to 2 mils per kg per hour, along with furosemide 20 milligrams IV OD, with more frequent sodium monitoring, so every 2 to 3 hours, and adjusting the infusion based on the sodium levels. It's also important in these cases to monitor potassium losses and replace accordingly. And the goal is the same as intermediate treatment protocol, which is to increase the sodium. Well, we have to increase it a little bit faster, sorry. So at a rate of 1 to 2 milliequivalents per liter per hour, but again, not exceeding 8 to 10 milliequivalents in 24 hours and 18 to 25 milliequivalents per liter in 48 hours. So I mentioned osmotic demyelination syndrome. So this is a complication associated with the rapid treatment and overcorrection of hyponatremia, and it includes central pontine myelinosis, which is a rare disorder of the pontine white matter, as well as extrapontine myelinosis. So symptoms can be early or late, and early symptoms include things like lethargy and affective symptoms, and late symptoms include flaccid paralysis, as well as cranial nerve abnormalities. So there are a few features that are common to patients who develop osmotic demyelination syndrome, and that includes things like delay in the diagnosis of hyponatremia with resultant respiratory arrest or seizures with probable hypoxemic events. It's also due to rapid correction to normal or even hypernatremia within 48 hours of initiating therapy. So like I said before, it's important that when correcting hyponatremia in these patients will not exceed 8 to 10 milliequivalents per liter in 24 hours. And for high-risk patients, so patients who are alcoholics or they're malnourished, or even patients with liver disease, we correct at a slower rate of 4 to 6 milliequivalents per liter in 24 hours. If there's an increase in serum sodium by greater than 25 milliequivalents per liter within 48 hours of initiation of therapy, and again, overcorrecting serum sodium in patients with hepatic encephalopathy or even hepatic disease, and if hyponatremia is present for greater than 24 hours prior to initiation of treatment. So these here are just some images showing how these conditions may look on MRI. So on the left, we see central pontine melanosis, and on the right, osmotic demyelination syndrome. So I've discussed SIDH, so now I'm going to move on to cerebral salt wasting. Now, this refers to the renal loss of sodium as a result of intracranial disease that results in hyponatremia with a decrease in extracellular fluid volume. The exact pathophysiology of cerebral salt wasting is unknown, but it can sometimes mimic SIADH. So there is the important need to differentiate cerebral salt wasting from SIADH, as the fluid restriction in cerebral salt wasting can exacerbate vasospasm-induced ischemia because dehydration increases the blood viscosity. We also do laboratory investigations. However, they may be identical in SIADH and cerebral salt wasting. Hypovolemia in cerebral salt wasting stimulates ADH release. And to differentiate the two, central venous pressure monitoring can be used. Pulmonary capillary wedge pressure as well as plasma volumes are low in hypovolemia in cases of cerebral salt wasting. So this here is just a table kind of comparing the two so that you can identify the differentiating factors between the two. I wouldn't get into it too much, but just to mention with cerebral salt wasting, there's a negative salt balance. However, it's variable in SIADH. Plasma volume is typically reduced in cerebral salt wasting and in SIADH, it may be increased or even normal. Signs of dehydration are typically present in cerebral salt wasting and they are absent in SIADH. So how do we treat patients who have cerebral salt wasting? The aim here is to treat hypovolemia aggressively and to achieve a positive salt balance. So we typically use crystalloid infusions, so 0.9% sodium chloride at a rate of 100 to 125 mils per hour. And in severe cases, hypertonic saline is used at a rate of 25 to 50 mils per hour. We do not use furosemide in these cases, while we do use it in SIADH. There's simultaneous oral salt replacement in these cases. Blood products are transfused if the patient is anemic, and because of the use of sodium chloride, one must be aware of the risk of hyperchloremic acidosis, as the treatment of it is a lot more difficult than its prevention. Hyperchloremic acidosis is a metabolic acidosis that augments the inflammatory response and decreases renal cortical blood flow, as well as reduces gastric mucosal perfusion, leading to tachypnea, hypocapnia, and thereby there's an increased risk of cerebral vasoconstriction. Fludrocortisone acetate can be used at a dose of 0.2 milligrams either orally or IV OD, and this acts directly on the renal tubules to increase sodium absorption. However, it is associated with pulmonary edema, hypokalemia, and hypertension. Urea can also be used, especially when the cause of hyponatremia needs to be determined, so you're unsure whether this patient has SIADH or cerebral salt wasting. And it's at a dose of 0.5 grams per kilogram, dissolving 40 grams in 100 to 150 mils of normal saline IV over 30 to 60 minutes every 8 hours. So I've discussed hyponatremia. Now I'm going to move on to hypernatremia. So hypernatremia is defined as a serum sodium greater than 150 milliequivalents per liter, and it's often seen in the setting of diabetes insipidus. Now, in these cases, we must estimate the patient's current total body weight, and that is calculated by the formula that you see on the screen in front of you. So 140 milliequivalents per liter by 0.6 by the patient's usual body weight in kilograms divided by the current concentration of sodium. It's important in these cases as well to replace the free water, and we correct it slowly in order to avoid exacerbating cerebral edema. So in order to calculate the free water deficit, it's by the formula that you see on the screen as well. So the current sodium minus 140 over, again, the current sodium by zero point 0.6 by the patient's usual body weight. In order to accurately calculate the free water deficit, you could use the formula. However, there are multiple apps available to calculate the free water deficit as well. So this here is just a screenshot of the free water deficit calculator by MD Calc. So you can see here that it takes into consideration a few factors. So the sex of the patient, whether they're male or female, their age, their weight. It calculates in either pounds or kilograms. You can adjust it to suit the sodium levels of the patient and the level of sodium desired. So once you input the values, it calculates the fluid deficit for you, and you replace it by just going back to the previous slide, a half of the water deficit over 24 hours, and then the other half over the next 1 to 2 days. So, getting into diabetes insipidus, this is due to insufficient antidiuretic hormone activity in the kidneys, which leads to excessive renal loss of water and electrolytes. And there are two etiologies that are implicated. So, the first one being central or neurogenic diabetes insipidus, which involves subnormal levels of ADH that is caused by the hypothalamic pituitary axis dysfunction. And this is the more common type that is seen in neurosurgical patients. The other etiology that is implicated is nephrogenic diabetes insipidus, which refers to renal resistance to normal or even supranormal levels of antidiuretic hormone. This here is just a table comparing the causes of each of the etiologies. So in cases of central or neurogenic diabetes insipidus, it can be autosomal dominant, can be idiopathic. It can also be due to post-traumatic changes. So whether it be injury to the brain or even post-operatively. Can also be due to tumors, namely craniopharyngiomas, even metastatic disease and lymphomas, granulomatous diseases such as sarcoidosis and histiocytosis, infectious causes such as meningitis and encephalitis, as well as autoimmune and vascular causes as well. In nephrogenic diabetes insipidus, it can be X-linked recessive, can also be due to electrolyte abnormalities such as hypokalemia and hypercalcemia, Sjogren's syndrome, medications such as lithium and colchicine, chronic renal disease, and in cases such as pyelonephritis, amyloidosis, and polycystic kidney disease, as well as granulomatous conditions such as sarcoidosis. So, in central diabetes insipidus, 85% of ADH secretory capacity must be lost before clinical diabetes insipidus ensues. And some characteristics include polyuria with low urine osmolality and polydipsia in a conscious patient. So some differentials for central diabetes insipidus include, again, well, neurogenic DI, which is considered to be a true DI, nephrogenic diabetes insipidus. It can be psychogenic, which can be subcategorized into idiopathic or even psychogenic polydipsia, which is as a result of excess free water intake. It can also be to osmotic diuresis, so following mannitol infusion, or even due to diuretic use, so furosemide use and even hydrochlorothiazide use. Like I said before, it can also occur postoperatively, so namely implicated in transsphenoidal surgery or even craniopharyngioma resection, and this is due to injury to the pituitary stalk. So there's transient diabetes insipidus, which typically normalizes in 12 to 36 hours postoperatively, and in these cases, it's important to avoid long-acting agents. Prolonged diabetes insipidus refers to supranormal urine output for months to years or even permanently. There's also the triphasic response, which, as the name suggests, has three phases of DI. So phase one involves injury to the pituitary gland, which reduces ADH levels for 4 to 5 days, resulting in diabetes insipidus. Phase two involves cell death, which liberates ADH for the next 4 to 5 days, and this is transient normalization, or even SIADH-like water retention. And phase three involves reduced or absent ADH secretion, which can either be transient or even prolonged. So this here is just another slide that outlines the causes that I would have previously discussed. So again, traumatic brain injury and post-surgical changes increase the risk of central diabetes insipidus with respect to traumatic brain injury, mainly basal skull fractures. Can be idiopathic. Hypoxic brain injury or even brainstem death results in the cessation of hypothalamic production of ADH. And pituitary adenomas, craniopharyngiomas, and even suprasellar germ cell tumors are also implicated in central diabetes insipidus. So how do we diagnose these patients? So firstly, there's the presence of dilute urine. So the urine osmolality less than 200 milliosmoles per kilogram or urine specific gravity less than 1.003 must be present. The patient must also be unable to concentrate the urine to greater than 300 milliosmoles per kilogram in the presence of clinical dehydration, a urine output greater than 200 mils per hour, normal or above normal serum sodium, as well as normal adrenal function. In the event that the diagnosis of diabetes insipidus is still unclear at this point, one can proceed to conducting the water deprivation test. So it's important for the water deprivation test that we exercise extreme caution because of the risk of rapid and potentially fatal dehydration, and is usually rarely necessary if the serum osmolality is greater than 298 milliosmoles per kilogram. So how do we conduct this? Firstly, we stop all intravenous fluids, keep the patient NPO, monitor urine osmolality hourly, as well as weigh the patient hourly, and continue until one of the following occurs. So we continue until the patient has a normal response, so urine output decreases and urine osmolality increases to 600 to 850 milliosmoles per kilogram. There's a 6 to 7 hour time lapse. Urine osmolality plateaus, or the patient loses 3% of their body weight. If still the patient doesn't have any response, we can consider the administration of exogenous antidiuretic hormone and assess urine osmolality in 30 to 60 minutes, comparing the highest urine osmolalities before and after exogenous ADH administration. So, in the event that there is a less than 5% increase in urine osmolality, that's considered a normal response. If the patient has a 6 to 67% increase following administration of exogenous ADH, that indicates a partial ADH deficiency. If the patient has greater than a 67% increase in the urine osmolality following administration of exogenous ADH, that indicates severe ADH deficiency. So the treatment of diabetes insipidus depends on whether the patient is conscious or unconscious. So in the conscious ambulatory patient who has mild diabetes insipidus, the patient only drinks when thirsty, and this is because the natural thirst mechanism is intact. In cases of severe diabetes insipidus, one can consider desmopressin administration, and this is given at a dose of 2 to 4 micrograms, either IV or subcut, either once or twice a day, and it's titrated against the urine output. And it's typically used in conjunction with a desmopressin nasal spray at a dose of 2.5 micrograms BD, titrated up to 20 micrograms BD as needed, again, based on the urine output. ADH enhancing medication can also be considered in cases of chronic partial ADH deficiency. So things like clofibrates at 500 milligrams PO QID, even chlorpropamide, which increases renal sensitivity to ADH, and hydrochlorothiazide, as thiazide diuretics may act by depleting sodium, which thereby increases reabsorption in proximal tubules, shifting fluid away from distal tubules, which is where ADH works. So in the non-ambulatory and comatose patient or even a brain dead patient, strict input-output charting hourly is required with the monitoring of urine specific gravity every 4 hours when and whenever urine output exceeds 250 mils per hour. It's important to also assess labs, mainly serum electrolytes with osmolality every 6 hours, and IV fluid management. So this involves 5% dextrose with a half normal saline, so that's 0.45% sodium chloride, with potassium replacement at 20 milliequivalents of KCl at appropriate rates. We also need to replace urine output above the base IV rate mil for mil with half normal saline. If the patient is unable to keep up with fluid losses with either IV or even NG replacement, then one can consider either vasopressin or desmopressin administration. So I've spoken about hyponatremia and two main conditions that are implicated in neurosurgery, which is SIADH and cerebral salt wasting. And I've also discussed the main condition implicated in hyponatremia, which is diabetes insipidus. So I'm gonna get into a clinical scenario to kind of help tie everything in a little bit, right? So here we have a 52-year-old woman who is admitted with a sudden severe headache, vomiting, and brief loss of consciousness. She has a CT brain non-contrast, which confirms a subarachnoid hemorrhage due to a ruptured anterior communicating artery aneurysm. She subsequently undergoes successful endovascular coiling and is managed in the ICU. So day 1 to 3 post-op, she's stable neurologically, receiving high IV fluids and imodipine, and her serum sodium is at 1 to the 8. So nothing really to talk about here. By day 5 post-op, the nurses report increasing confusion, lethargy, mild headache recurrence. However, they report the absence of seizures. Her vitals at this time, she's normotensive at 130 on 80 with a heart rate of 78. There's no orthostatic hypotension, no peripheral edema, her mucous membranes are moist. And this is her fluid balance. So her urine output is about 1.2 to 1.5 liters per day. So not anything particularly excessive. So day 5 post-op, this is what her labs are noted to be. So her serum sodium has now dropped from 1 to the 8 to 128. Serum osmolality at 260. Urine osmolality increased at 550. Her urine sodium increased at 60. And her urine specific gravity is increased. So she has particularly concentrated urine, with the urine specific gravity being greater than 1.020. So what do we have here? We have a patient who has acute hyponatremia within the last 48 hours, a low serum osmolality, inappropriately concentrated urine, a high urine sodium, and she's euvolemic as assessed by her normotensive state, her heart rate being normal, as well as her on clinical assessment, her mucous membranes were moist. So all of these things are consistent with SIADH following a subarachnoid hemorrhage. So how do we manage these patients? So like I said before, normal saline infusion with furosemide 20 milligrams IVOD, monitoring of sodium every 4 hours with the goal of increasing sodium at a rate of 0.5 to 2 milliequivalents per liter per hour, not exceeding 8 to 10 milliequivalents per liter in 24. Now, this, as you can, I don't know if you're able to remember, this would be consistent with the intermediate treatment protocol. That's because this patient has not exhibited severe signs of hyponatremia, so you wouldn't proceed to aggressive sodium replacement in these cases. So getting into another clinical scenario, right? So here we have a 34-year-old woman who's diagnosed with a non-functional pituitary macroadenoma who undergoes transsphenoidal resection of a pituitary macroadenoma that has been compressing the uptake chiasm. Surgery is uneventful and she is subsequently transferred to the neurosurgical ward. In the first 12 to 48 hours, nurses report that the patient has excessive urine output between 300 to 500 mils per hour, and she's complaining of intense thirst and frequently requesting water. So these are her vital signs. So she is hypotensive with a BP of 100 over 65, and she is slightly tachycardic with a heart rate of 105. On assessment, mucous membranes are dry, and her urine output is greater than 5 to 6 liters per day when calculated. So when her labs were done, it was noted that her serum sodium was increased at 152, with an increased serum osmolality at 310, decreased urine osmolality at 80, and dilute urine with a urine specific gravity of less than 1.005. So here we have a patient who is experiencing polyuria. She's hyponatremic, has a high serum osmolality, and inappropriately dilute urine. So all of these things are consistent with central diabetes insipidus due to ADH deficiency following transsphenoidal resection of pituitary macroadenoma. So how do we manage these patients? Well, we manage via replacing the free water deficit, which we calculated via either the formula that I previously discussed or using the calculators that are readily available online. One can consider the administration of desmopressin at 2 to 4 micrograms IV or subcut OD or BD, again, titrated against urine output with strict hourly input-output charting and monitoring of sodium levels every 4 to 6 hours. So these are my references. Thank you very much.